to placebo is great, but it's nice to have a comparative analysis that can help us guide our selection of antidepressants. Here are the antidepressants that were in the study. Sure you've all memorized those by now. So obviously a ton of them. Some of them that you don't see much. Agomelatine is actually not available in the US. Reboxetine I've never used or even seen anybody use. Anafranil, clomipramine is tricyclic that people don't use very often. You see that Sarazone's on there. We talked about the issues that Sarazone has with potentially liver toxicity. So good news, all the antidepressants were better than placebo. All right, good starting place, right? Here's the core kind of summary of this. The most effective in the head-to-head studies of the antidepressants are listed here. Now, this does not mean best tolerated. This is most effective. And it's interesting because it's not generally, it's not completely what I would expect based on my experiences with some of these medications. So it's very interesting to look at. So we see that Lexapro and Remeron and Effexor are on the that makes sense to me. But interestingly, also Paxil, which is not indicated for children or adolescents. And you see that, notice agomelatine's on there, which is not available in the US. Least effective, you take a look at this, I don't think we're surprised on any of those, except I'm surprised on Prozac. With least effective, I use Prozac fairly often and find that it can be pretty effective, particularly at the higher doses, closer to the 80 milligrams a day. But again, interesting to see. Best tolerated. So interesting to see that Prozac was best tolerated and on the least effective list as well. Best tolerated, there's the agomelatine again. And notice that it was one of the better performers. Celexa and Lexapro, we expect those two SSRIs to do pretty well, right? Zoloft, middle of the road antidepressant, used a lot, well tolerated. Interesting, the vortioxetine that I talked about using that I haven't used very often, well tolerated medication. Least well tolerated, not surprising to see the tricyclics on there, amitriptyline and clomipramine. Duloxetine, not well tolerated. I sort of have that experience with it, I guess. Not so much more than others. Trazodone, of course, is remarkably sedating. And there's Effexor, least well tolerated. That's interesting. Now, Effexor, in my experience, remember I use this as a first line a lot myself in my practice. And you do get some nausea with Effexor sometime, but if we look back on most effective, there's Effexor, and least well tolerated, there's Effexor again. So interesting, right? And then here's the combination, sort of, when they kind of worked out what would be the most effective and the best tolerated. Here's your list. So you've got a pretty good rationale for using any of these medications. I think it's interesting that most effective and best tolerated is mirtazapine's on that list, since we know it's super sedating, and people often have intolerable weight gain on it. So interesting. There's that agomelatine again. Kind of sad that it's not available in the US. I would like to use that. That seems like it has outperformed a lot of things on there. And then Paxil ends up being on this list, which again, that one kind of surprises me a little bit as well. But there you go. If you're interested in, looking at this in a rational, evidence-based manner, your choices of medication, here are some pretty reasonable choices based on both tolerability and efficacy. Let's look at side effects and treatment of side effects here. What you might do. We've talked about sexual dysfunction SSRI-induced sexual dysfunction, and we've talked about Wellbutrin and Buspar. So weight gain, avoiding Remeron, no surprise, and Paxil, both kind of weight gainers. Interesting that Wellbutrin can be associated, I like to think of Wellbutrin as being associated with either neutral or possibly some weight loss on that. I wouldn't say significant weight loss, but that is an interesting choice. So if your patient is depressed and not particularly anxious, Wellbutrin is a great starting point. Diarrhea, avoid sertraline. Remember that you've got serotonin receptors in the gut. Nausea and vomiting, I mentioned earlier, that Effexor can lead towards nausea. So again, these are ways, part of choosing your antidepressant is really looking at what side effects do we want to use and what side effects do we want to avoid? What are the strengths and weaknesses for this particular medicine for this particular patient? If you've got a patient who is going through chemo and has a lot of nausea, well, you might not want to use something like Effexor with that particular patient. If you've got a patient who is going to abruptly stop their medication without consulting you, you might want to avoid using any of the medications that have that discontinuation syndrome that you see there. So reasonable to consider. I will tell you that discontinuation syndrome, many patients describe that to me on both duloxetine and Effexor, and people describe feeling spacey, lightheaded, having sort of this sensation of electrical shock shooting through them. Very odd kind of descriptions of that. That's interesting because I've also had physicians who have been prescribed this and have this discontinuation syndrome, and they also describe the kind of electrical shooting sensation as well. Remember, we put Prozac on there if you're worried about people abruptly stopping stuff, because it has that long half-life and it's going to taper itself and is tolerant to poor adherence. So this is an interesting slide. This is sort of, what is it that you're sort of going to see with patients when they have a reasonable response to an SSRI? What are sort of the leftover symptoms that you might have to address? This is the case in which for insomnia, you might be, from a pharmacological perspective, you might be thinking about using a sleep agent, right? Sending them for CBTI. Fatigue, maybe you're thinking about a switch to a medication that's less fatiguing. Physical pain, we've talked about some of the strategies for that. Do you want to consider a switch to a medication that might have, or adding a medication that might help with that? Concentration, we know that Wellbutrin is going to be strong for concentration, possibly for vortioxetine, Trintellix. And lack of interest or motivation, we know we want to avoid things like Paxil, anything that's going to be more sedating. Okay. So when we think about approaching how we're going to choose an antidepressant, here are eight questions that we should be asking ourselves. And this is low-hanging fruit here, right? What's worked and not worked in the past? And you would be shocked at how many people forget to bother to ask this question. You know, we sit down with patients and we start working through, what are we going to start them on? And often enough, they ended up just getting started on whatever that provider likes. Providers kind of get attached to different medications. You know that one of my propensity is to start Effexor, but I don't start Effexor in everyone. I want to match my medication to the patient needs and side effects. And I also want to ask this question, you know, if like my patient who I mentioned that had done really well on Savella, which is milnacipran and SNRI, and was discontinued for no good reason, and then was tried on other stuff that didn't work very well. This was low-hanging fruit, right? We just restarted Savella and she's doing terrific. We don't have to reinvent the wheel. Certainly we don't need, if there is a history where patients tell me they didn't do well on a medication, I don't bother trying them. I just don't go there unless there's really good reason to consider that medication. Genetics. easy on this one. I mean, there is genetic psychiatry, and I certainly don't order any of those genetic histories. It's not something that the government's going to pay for. But it is easy to ask, hey, does any of your family members have similar symptoms, and are they taking any medication? How are they doing? Make sure your patient isn't adopted before you ask that question. But this is an easy way to make a decision about what medication you might want to try. Number 3 there, cost. It tends to not be an issue for me within the military system. Patients don't pay for their medications when they're prescribed through, but if you outside of that system, cost can be a real issue. And do you really want to be prescribing the shiniest, newest medication? And is that really even going to be the best medication? You're going to need to know what is on your formulary and what's not on your formulary. Or I should say, as somebody pointed out earlier, what's on the formulary of the insurance company that your patient is on. We spent a lot of time talking about this, right? How do you target the symptoms that your patient has? What are the strengths and weaknesses of individual antidepressants that we've just reviewed that we can use to address lethargy and amotivation? And which ones should we avoid? Right? What side effects are we trying to avoid? This is where you can have like a very frank conversation with your patient. And you talk about side effects and say, well, when we're selecting a medication, what is it you're not going to tolerate? What is it that's going to make you just stop taking this medication no matter what? No matter how well it works, you'll stop it if what happens? I often hear that around weight gain. For my patients, obviously, my patients are frequently active duty soldiers. But weight gain tends to be one that is not tolerable for a lot of folks. Sexual side effects as well. Although, remember, we can do something about the sexual side effects. Drug interactions. This is why it's so important that you do a reconciliation of their medication. You need to know what they're taking, what else they're taking. And when you start a medication, in general, it should be your practice to run a drug interaction. You can use drugs.com. I use Hippocrates. I presume you're all familiar with Hippocrates. I have a free subscription, and in the 11 years I've been using it, I've never done the paid subscription. I haven't needed it. And I run those drug-drug interactions just to see where we're at. Just because there is a potential drug interaction, right? It doesn't mean it's not a drug you should use, but it is something we should address. If you're aware that there's a drug interaction, that perhaps, let's say, the patient is taking a tramadol or taking one of the triptans, rizatriptan, or another drug, let's see, and I'm just naming drugs that are not SSRIs that contain serotonin. So tramadol, the triptans, some of the muscle relaxants can contain serotonin. And in that case, you would want to make a note that you're starting an SSRI and that you've warned the patient about serotonin syndrome. You've gone over with them what the signs and symptoms of serotonin symptom are. And if those were to occur, that they are to stop taking the medication and contact their provider. So looking at drug interactions is going to be important, and then medical comorbidities. So can we hit, we're not necessarily treating pain, but if I have a patient who has insomnia, neuropathic pain, or migraines and depression, I'm going to tend towards something that might hit all of those. Something that might be sedating, something that might help with peripheral pain, and something that helps with mood. And we can choose something in that way. So you want to take into consideration the whole picture of the patient. And then patient preference is really important too. I put a lot of weight on patient preference. There's a lot to be said for placebo, right? The patient says, well, I have a friend who tried Zoloft, and they said it was the best medication in the world, and I've always wanted to try Zoloft. Unless there's a good reason not to, I'm probably going to start them on Zoloft. They already have buy-in. They're already interested in it. We've kickstarted the placebo effect already without having to work at it. It's a good place to go. Just wanted to cover this really quickly, and just as a reminder more than anything else, that you want to remember that we may have to treat depression that is secondary to a general medical condition. And that if that medical condition is appropriately treated, we may not be needing to treat the depression. Right? So we want to know the difference, and we want to be aware of what the correlation, or at least the relationship, between depression and different disorders are. You can read that list for yourself. Obviously, anemia can look like depression. That doesn't mean that people with depression don't get anemia. They do. But sometimes people who are anemic just present with depressive symptoms, usually a lethargic, amotivated, hypersomniac-like depression that when we look at their labs and we see that their red blood cell count is low, hemoglobin, we can get that corrected and they might get better. Sleep apnea, same thing. There's a high correlation in people with sleep apnea and depression, and sometimes if you treat the sleep apnea, we can see people get better and their depression lift. Asthma, chronic fatigue syndrome, obviously chronic infections and pain, congestive heart failure, very common to see depression there. Diabetes, thyroid disorders, hepatitis, multiple sclerosis, Parkinson's. Let's see these things. I see quite a few of these things in my patients. I have a 22-year-old woman with Huntington's disease. It's a genetic relationship. Her mother died of Huntington's disease when she was 30, and passed on the genetic predisposition to her daughter, who's 22 and is probably not going to make it to 30. Not surprisingly, is depressed. Patients, I have a patient with SLE, systemic lupus erythematosus. Definitely a relationship with depression there. I have multiple patients with RA. Some drugs that can cause depression. These are one of those things that you want to, this is why you want to do that good reconciliation with the medications. So lots of patients take antihypertensive. So for example, beta blockers like metoprolol, propranolol, et cetera, can cause depression. This is where psychologists really earn their keep, is we get good histories, right? And we want to know the question of what was the onset of this depression. And if you can link the onset of the depression with a beta blocker, particularly in a person who has no history of depression and has a sudden onset depression in their 40s or 50s, your first guess should be a medication problem or a medical issue. You can see that steroids, not surprisingly, anxiety or depression or psychosis can be a problem with that. The benzodiazepines, many pluses and minuses on the benzodiazepines, but they can result in depression, birth control. Anytime we're messing with hormones, we can have that effect. Again, you want to be asking the question on your female patients, when was the onset? You want to take a look at their medication list and see if that onset of the symptoms that they're complaining of coincide with any start of a medication. Disorders that can cause anxiety. PHEO, I don't know if you guys have gone over PHEO. It's a benign adrenal tumor, pheochromocytoma. I've actually tested patients for this a couple of times, but it's a real zebra. It's very uncommon. It's unlikely to happen. You can read the rest of this list. Right, that last one there, stimulants, that's interesting, right? Because there's a comorbidity between ADHD and anxiety. I will tell you that I often find that for my anxious patients who have ADHD, that when I adequately treat their ADHD, their anxiety gets better because they're coping better in the world. They're getting more done. They're not staying up at night thinking of all the stuff they forgot to do because they are completing tasks better at that point. They're kind of more on target with things and paradoxically end up sleeping better, which is weird because I'm giving them stimulant medications, but we are treating the underlying issue. All right, we're gonna do a couple of questions here for the group, and this is kind of our first trial. I'm gonna pull up a question. I think we have a way for Aiden, for everybody to vote on the answer to this question. Is that right? All right, yeah, and
Yes.
the answer is yes. There we go. Okay, what do you guys think? Antidepressants were what most common prescription drug taken by Americans? What do you think? So nobody went for A. Most people went for C so far. Looks like people are still voting. No takers on D. Okay, so the answer to that one is C, third. Good job. Now, hey, Aiden, am I supposed to click on end poll to end that particular poll?
Yes, doctor. Whenever you feel is enough for a question, and you can also share the result if you wish.
Oh, I thought everybody could see the results. Sorry. Here's the results, guys. Okay, let's go to the next question. Do I have to, Aiden, I'm sorry, guys, for this, but do I have to exit out of this poll to get the next one? I just did.
I can do that. It's okay. I can do that.
So let's see what happens. All right, next question. Which SSRI is likely to be the best tolerated in its class? All right, take a few more seconds here and we'll get the last few in here. Okay, I'm gonna vote if you want to right now because I'm gonna end the poll. And let me share those results. There we go. So escitalopram or Lexapro was the correct choice. Paxil is actually one of the least well tolerated in some ways, but when you saw that, but isn't that interesting? Because when we looked at that network meta-analysis, it's not what it said, right? So it's interesting, all the different contradicting sort of information. What I would suggest is that you consider within the SSRIs, if you're looking for something that has the least set of side effects, I would start with Lexapro. I think there's the most data to suggest that. All right. And try. Oh, next question. Which SSRI does not require, oops, covered my, does not require a taper with discontinuing? And everybody, let's see. All right, has everybody voted? Looks like everybody's voted. So results here, fluoxetine is the correct answer on that one. Remember, it has that really long half-life. Okay, and then let's go to next slide. Which of the following medications might you consider adding to an SSRI to improve the side effect of SSRI-induced sexual dysfunction? Okay, we're gonna end voting there. And you guys are on it. Yep, Wellbutrin, bupropion. Good. All right, and then we're on to the next slide. We're moving away from, I believe, antidepressants now. Does anybody have any questions that they wanted to ask about antidepressants before we move forward? And I'll just look at the chat here and see if anything pops up. If not, we'll move forward. Okay. So I include this, the culture and language of medicine. For those of you who work in primary care settings or with physicians on a regular basis, I think this will seem very true to you. This was a steep learning curve for me. I had not worked previously with physicians before I was embedded in primary care, and I had to learn this sort of the hard way. And this is something that Marlon Hoover, who probably most of you know of, he's been a big figure in RxP, and John Andazola, who's a primary care doctor in New Mexico, who's worked closely with Dr. Hoover over the years. They put together this article that was quite good and talked about how psychologists and medical providers really differ in how they approach things. And you really have to know, you have to be able to wear both hats. You have to be able to have a foot in both worlds when you're a prescribing psychologist. Psychologists drive physicians nuts, and physicians drive psychologists nuts. And this is why, this slide right here. Psychologists, we beat it to death. We are taught to be thorough. We need to cross every T, dot every I. I want the entire background, start at the beginning. Don't make it brief. I want to see the whole thing. And in fact, I'm going to punish you and grade you down if you don't give me, the entire background and cite every reference that has ever been written on this topic. And so we tend to be long-winded, right? We sort of start with, well, they were born. And physicians, in a much more time crunch sort of way, tend to be more to the point. And of course, I'm making generalizations. Many of you are probably to the point. But as a group, psychologists tend to be a little bit more thorough. We tend to cover all the bases. We look at everything from top to bottom, right? We talk about biopsychosocial. We're going to hit bio, we're going to hit psycho, we're going to hit social. We're going to get everything. Whereas physicians, again, more to the point, they're just going to say, what are the top 2 things I need to hit here? We don't know. This is very important. We don't diagnose until the data are definitive, right? When was the last time you said, well, I've only known you for 2 minutes, but I don't know, I got a good gut sense about PTSD with you. That's what we're going to go with. We don't do that, right? We're like, hey, if you don't meet the criteria for PTSD, you do not have PTSD. That's just the way this works because we know better, right? And we know that we have to do that because otherwise we're going to be treating something we don't know what we're doing. Within medicine, however, they often have to make definitive decisions on ambiguous data. That is really true, right? Think about your own primary care doctor or provider and your experience with them. They've got 20 minutes. And, think of more complex patients that have like 5 or 6 significant complaints, right? and they're coming in to talk about them, they need to do something in that 20 minutes. They can't kick the can down the road. They don't go, well, I'm going to see you in 2 weeks and we'll talk about this again. My providers, my medical providers, they can't see people for another month or two. And so they are under the gun to do something today and now and make a decision about it. In fact, that's how they're trained. I'll talk about the training model in just a minute. So our education is based more on reading than apprenticeship, and it's opposite for physicians, right? They go to medical school and get the training, and then they go practice it. That's what residency is for them, is they go get a panel of patients, and then they're expected to practice it. There is a kind of a saying in medicine that says, see one, do one, teach one. They mean it. So this should give you pause next time you go get a vasectomy, men, right? Because they really do. It really does work this way. So for example, circumcisions, our family medicine providers, they got on newborn and they literally go see a circumcision done. Then they do a circumcision or two, maybe 10. And then the next resident who comes on board who hasn't done one before, they end up teaching it to them. So this is a model that they use and they're comfortable with. That would be, for me, incredibly anxiety provoking. We are responsible to not do something, right? I love that P is less than 0.05, right? That's how we think. We're like, yeah, no, I can't be absolutely sure, so I am not going to screw this up. Whereas the physician says, I got to do something today. It might be wrong, but maybe it'll give us some feedback about what I should do next time. Two really different ways of being in the world. And we are expected to study what we're being shown before we do anything about it. They are expected to do it now, right? And that's really different. We get seen, right? We get to watch somebody working with somebody in therapy. It's very interesting. We go back, we read about it, we think about it, we practice it, and then maybe we do something with it. They get to watch a vasectomy, and then the next procedure that comes in, the next vasectomy, literally within the next 50 minutes, they are handed the scalpel, okay? So it's a very different kind of experience. Yeah, comments here, as a field, we're moving towards doing things more quickly. I agree. And you really don't want to frustrate your resident. You're treating you in July, August, or September. There's somebody who works with them. So yeah, it's an interesting world. Let's just put it that way. And the way that if you work in family medicine residency, you understand this, but I didn't when I started working. The way that this works is that it's a 3-year residency. The first year they're called interns, even though they're also a first-year resident. The second year, they're second-year residents, third-year residents, and then they graduate. So what they do is they see a patient, and then they go back to something called the attending room, and the attending is the supervising physician. They are then asked to do a report, a thorough report, briefly, to the attending on what's happening with the patient. So they do a review of systems, what medications the patient's on, what their differential diagnosis is, what decision they've made, what they think the issue is, and what they think the plan ought to be. And they get taught this, and they do it over and over again. It's fascinating to watch this, and they get better and better at presenting this over time, and they have to put together a great deal of information in a very short amount of time. And that is how they learn. And as a psychologist, I went in my first 6 months there, I went and sat in the attending room 2 or 3 times a week for an hour or more, just to kind of learn how they think, how they thought, how they approached things. And I just brought a medical dictionary with me and I looked up everything I didn't understand, which is an interesting way to learn, but it worked pretty well. So knowing this is incredibly important to know this different, because once you are a prescriber, they assume you are like them. They assume you know what they know, and they assume that you're like them, and I mean it. It really does work that way, guys. And again, some of you may know this very well. they suggest, Hoover and Andazola suggest that you shadow a physician. That's usually part of your training. Getting a mentorship with a health psychologist, interviewing physicians, reading books about medical culture, and you got my advice on there, observe an attending physician. Of course, this is assuming we all have nothing but time to do these things. If you have the opportunity to do some of these things, in particular, if you ever get an opportunity in a training facility to go observe an attending physician with residents, it's a very powerful experience. Really, you get a lot of bang for the buck in terms of understanding how physicians are trained and shaped to communicate and think the way that they do. I like to point this out. I've kind of mentioned this a few times. We are all individuals. Prescribers have favorite drugs. And I'm really talking to you as psychologists right now who are going to be working with people who are prescribing. Some of you will go on to become prescribers, I hope. We passed that law in California. A lot of you will be. But in the meantime, while you're working with prescribers and talking to them, don't forget that they're just going to have biases like everybody else does, right? They're going to have their favorite medication. And you have to take that into consideration when you're talking to them about that, right? Just know that this is a bias. And you need to know your own biases about this. And as you get to know providers that you work with, know their biases too, because you may have to gently suggest to some folks that they want to consider something else or a different medication, right? My suggestions, what I've learned, now I work in a very formal system. I am sir and doctor all the time because most of the people I work with, well, actually all of the physicians I work with, all the residents are active duty. Many of my other doctors are active duty, and the rest of them are retired active duty. So it's a very formal system. And even though I've known people for 10 years, they still refer to me as Dr. Scheer sometimes. Yes, we get less formal in other circumstances, but it's very formal. If you're as old as I am, or if you like old movies, there's a movie called Spies Like Us, which is pretty hilarious, where there's a group of doctors that get together and they greet each other by nodding and saying, "Doctor, doctor." Maybe some of you have seen this before. Look it up if you haven't seen it. I'm sure it's on YouTube. And they go around introducing each person as doctor. I'm getting a little feedback. All right, can you guys hear me okay?
I can hear the echo too.
Guys, I hope these are, yes, you've seen the movie, Doctor one. So anyway, it is like that a little bit. So physicians expect, and I am talking particularly about physicians, not PAs or nurse practitioners. They can get hooked up on formalities. And so if you're starting a new relationship with a provider, start formal. That's just my recommendation. You got to know your medical terms. I will tell you right now, they're going to assume that you know what they're talking about. I've had more discussions with physicians where they'd use medical lingo in their conversation with me. And I have to stop them and ask them, you know, well, what is that? Well, of course, that's a steep learning curve, and I've learned a lot that way, and that's fine. But it really does speak to the fact that they assume you know they know. One of the things you want to make sure you do have is you want to have a good reference like Stahl's Prescriber's Guide or others. There's a lot of good ones out there. You want to keep it incredibly brief. You really got to get to the point right away. Don't start with the story, start with your question. I'm seeing your patient. I have a question about the antidepressant that they've started on because I'm seeing some side effects. I'm wondering if you would be interested in considering some alternatives. Let's discuss that. That's that you want to get right to the point. And then I put that last piece on there, don't practice medicine without a license. Be careful. Information is free. Knowledge is, you can have all of this knowledge. Just be careful to not use language like I recommend or you should use. Always couch that in you may wish to consider. The evidence suggests, whatever language you want to use on that. Okay. Hey, any comments or thoughts on that, guys? All right. Let's go ahead and let's start working on this. This is actually something I'm going to go over relatively quickly. A lot of the treatments for addiction are not medication, that's therapy. So we're going to fly through this a little bit. There's a lot of slides on this. So you can go back and look at them if you want. Essentially, you know, this is addictions treatment has not been a strength of mine. And as a way to learn a lot more about it, because it became obvious to me that I was not going to do as good a job as I needed to do if I didn't know more about it. I read this book, Addictions Treatment by Michael Weaver through Carlott's Publishing. And I thought it was very good. And so what I did was I just outlined the entire thing. And I'm bringing that to you, kind of these are the cliff notes from this. And we're going to focus on a few drugs of abuse. And some of you are going to know a lot more about this perhaps than I do. So feel free to chime in and we'll talk about it. But we're going to kind of hit the high points on addiction. I don't think we need to go over there. These are the mnemonics for remembering things. I just want to remind everybody that it's substance use disorder. Changed the wording in the DSM. It's a little bit easier to use now. Mild substance use disorder, 2 to 3 criteria. Moderate, severe, 6 or more. And here are the criteria again, right? Tolerance and withdrawal, 1 and 2. Loss of control. Social consequences, right? Risky use. So heritability of addiction, 60%, it's estimated around 60%. Tells you that question that we ask about people's parents, right? And other family members, is there a history, right? So when people tell me that their parent is an alcoholic or what is a recovered alcoholic or substance abuser, then I really take that very seriously into consideration and have conversations with them about medications and ask them, you know, do you have any concerns about that for yourself? You know what that looks like. Is that something that you feel susceptible to? Is it something you worry about? And I'm really cautious and very open about if I'm going to prescribe a drug that has any risk of addiction, right? Stimulants or benzodiazepines, etc. We're going to have that conversation because that risk for them is higher than it is for others. I think this is a lot of pretty straightforward stuff, right? We want to normalize the use of substances. You want to be you know, we as providers want to be pretty comfortable talking about this and asking questions about substance use. Even if you're not a substance use specialist, which I am not, of course we have to ask, right? So we need to know the answer to these questions. Here are some of the things that we would ask questions about. So drug testing. So who should you order drug testing for? And when I'm talking about drug testing, I'm talking about something called a UDS, the urine drug screen. There's a variety of, there's other ways that you can test, but typically testing is done through a urine drug screen. That is generally the way that we proceed. So probably anybody with a history of a substance use disorder should be something you should consider, right? Obviously, if you suspect that they're using. This is interesting. So if somebody is not doing well, you might want to consider a UDS as well. I can think of a number of patients that I didn't do a UDS on who did not seem to be doing well. And I live in the state of Washington, and guess what's legal here? Marijuana. So it turns out they weren't reporting to me that they were using marijuana, 3 times a day. And lo and behold, my Prozac is not, or my CBT is not making their depression better. How would you, I'll get to the how would you tell the patient we're testing him in a second. And then this is kind of actually a direction that I'm moving now, is that last line, is that I think I'm going to test all of my patients. I'm going to do a UDS. I haven't yet, and I think that's probably best practice. If there's taking a stimulant or a benzodiazepine, those are the controlled substances that I prescribe. And the reason being is that not only do I want to know that they're taking them and not taking something else, if they're not taking them, that's called diversion, and we want to track diversion. And anybody who works really a lot with substance abuse will know that substance abusers can be very, very good at convincing you of whatever it is they want to convince you so that they can get their drugs. So knowing this and having the documentation in there is probably a good idea, and it's certainly a direction that I'm moving. Yeah, that first one, false positives are extremely rare. I'm not sure I'm going to go with that, because I've already, in my career, I've seen probably 3 or 4 false positives, and I don't order that many UDSs. So, yeah. So one of the strategies of this is to ask the patient to get testing done on the same day. And if they don't, you can talk to them about that, why they didn't, right? So let me see if I have a slide in here about talking to them about this. I don't. So let me talk to you about how I would approach a patient on doing this. Yeah, Joy says we get false positives on the UAs all the time. I know, yeah. So I thought it was very interesting that they're extremely rare. It's like not my experience. So one of my favorite examples is this clearly like teetotaling human being who I had prescribed venlafaxine to, and it turns out that venlafaxine can pop positive for PCP on UDS. So I had this, awkward yet interesting conversation with the person that, they pop positive for PCP, and did a little bit of research and saw that, that person was obviously not abusing PCP, which would be pretty rare. And yeah, actually, Danielle, yeah, you do special testing for diabetics because they can show positive. Going to address that in a minute. Thanks for mentioning that. So when I talk to people about this, what I say is, hey, look, I give them a rationale. I test blank everyone for this, or the reason I'm testing you. I always give people a reason, and I always give them a little bit of an out as well. Like, hey, is there anything you want to tell me? If you're using something and that you'd be surprised or wouldn't be surprised would show up that we haven't talked about, that's really okay. This isn't about trying to catch you. I just want to know what you're taking or what goes into your system. I really try to take out the shame or any kind of accusations out of this. I mean, really what I'm trying to do is treat somebody. And if they have a substance use disorder, I'm not going to beat them up about it. I want to help them with it, right? So you really want to approach this in that manner. That look, we're here to try to help you, and if you think something's going to pop positive, let's talk about it, and then we'll go from there. And then if things do pop positive, you can get further, because it could be a very general positive, like for. Oh, so we're up for a break. I'm going to finish this topic, and then we're going to take a 10-minute break. Okay, guys? So how you approach them is just kind of matter-of-factly and explain, give them a good rationale for it. And if they say, hey, I don't want to do this, or I don't want to take that, that is just a conversation starter. I go, okay, tell me about it. What's going on, right? Let me read some of the comments here. Yeah, you know, the people who do keto who blow positive on breathalyzers. So good point. Yeah, so you can pop positive in a lot of different ways. So here is the basic UDS. When I put it into our system, I literally type in UDS and it comes up for the basic. So you get the amphetamines, cocaine, marijuana, phencyclidine, some of the opiates. And then, so like, for example, I had somebody pop positive on amphetamines, and it was because she had been using over-the-counter cold medication. And we were able to have the lab send it off for further testing that sample to define what it was. If you want to do a comprehensive UDS, then you get methadone, Z-drugs, set of the benzos, barbiturates, etc. All right, false positives, right? This is where we want to go with the false positives. All of these things can cause false positives, right? Amantadine, you can just look down that list. Wellbutrin, we use that. You can pop positive for amphetamines, for methamphetamines, or LSD. Awkward conversation, looks like you're using LSD. Carbamazepine, one of our drugs, clomipramine, can pop for methadone. You can look down this list of things that you might. Anything stands out to you there? Hydroxyzine, we use that a lot. That is an antihistamine. It's FDA approved for anxiety and sleep. Quetiapine or Seroquel, methadone. Ranitidine is just Zantac, right? Look at that. Zantac can pop for amphetamines. Rifampin. Let's see. Zoloft can pop for benzodiazepines. And there's my venlafaxine for PCP, right? See that I had that experience. So that gives you a. Ranitidine can also make you test positive for cancer. Interesting. Okay. Yeah, so use UDSs, but use them knowledgeably, and don't assume that a positive is a positive until you know more about it, right? When you see a patient and you bring them in general, my experience with my patients who are not incarcerated or anything, they tend to, if they pop positive for something and I bring them in and ask them about it, they'll tell me that, yeah, they used it, that drug, so you can have a good talk with them about it. Okay, so we're going to take a 10-minute break, and then we're going to come back and talk about alcohol. All right, guys, see you in 10 minutes. Get started again here. Aiden, can you send me a yes or something if you can hear me? Just want to do a sound check. Thank you.
Yes.
Be embarrassing to talk for an hour and have nobody hear me. All right. Okay, well, let's go ahead and get started again. We're going to talk, we're going to hit alcohol here. I think this is probably things that most of you are familiar with, what a standard drink is. This is a place where there is a role for medication, and we can talk about acamprosate, naltrexone, and disulfiram. I have used naltrexone and disulfiram with my patients. Although I've used not the Vivitrol. I've only used the pill form of naltrexone, which I think is Revia, and not the Vivitrol. Might have that backwards. Treatment of alcohol disorders, again, just sort of a reminder to everybody on this. Withdrawals, medically managed withdrawals are pharmacologically managed, frequently with benzodiazepines. There are things like clonidine. Just thinking about the metabolism of alcohol and how disulfiram works. It's interesting that that acetic acid on the bottom there is upside down. I swear it was not the last time I looked at this, but there you go. This is where disulfiram works right here. So you end up having a toxic buildup of acetaldehyde. Yeah, acetaldehyde is what that's supposed to read. And you end up feeling pretty bad. One patient that I had who was taking disulfiram said that even putting hand sanitizer on his hand that contained alcohol, he had a reaction to that where his hands turned bright red and felt uncomfortable. So disulfiram, let's see where we're going to go on talking about that. No, I'm going to talk about that now. So disulfiram is a medication that you want to use that helps people with abstinence. You don't want to use it, my memory is less than 12 hours after their last drink, because otherwise they'll have these unpleasant side effects. And you don't want to use, disulfiram really is a medication for somebody who is very motivated to not drink. This is a person who has to have a lot of internal motivation because they have to take it every day to make it work. You can take the injected the version, right, which I think is the Vivitrol, which lasts longer and you don't have to take it by mouth. I haven't prescribed it that way. I really want my patients to be, if they're going to use disulfiram, it's going to be because they are really on board with not drinking and don't want to drink. And of course, you can choose to not take it and then drink. So it really has to be something where the patient is motivated and they just want that extra something that makes them not. And I've seen it be very useful for that. And I've seen it be basically useless in other people. So it really has to be for the right patient. And the other medications that we were talking about are naltrexone. I'm sorry, I've been mixing up. I've been mixing those two up, and I apologize. So disulfiram is Antabuse, and period. And then naltrexone is the one that can come in a depot shot. Okay. So sorry about that. If you have any questions about that, ask me. So basic questions, screening questions. You can read these here. So obviously alcohol is hard on the liver. I don't know how much time you guys have spent on labs, but you can look at liver function tests, which is basically the AST and ALT. And you're looking for elevations 4 times or above higher than the normal range. If the liver's not making coagulation factors, your INR PT can be elevated. So these the AST and ALT are part of, I generally don't end up ordering this lab by itself. I do occasionally order a liver function test by itself. remember I spoke about the patient that I have who started on nifazanone or Cerazone, and that drug is associated with liver toxicity in some people. And so for that particular patient, I will order literally an LFT, a liver function test. But for most of my patients, I end up getting AST and ALT as part of a comprehensive metabolic profile that I order that lets me look at electrolytes, glucose, and other things as well. So this is usually part of the CMP for me when I order that. You can see, like, if someone who's not a big drinker or doesn't have an alcohol problem, but they kind of binge drank last night, and then the night before they got their labs, you can see an elevation on the AST or ALT, but you're not going to see a huge elevation on it. Medications that are used for detox. So some of the longer acting, diazepam and clonazepam are some of the longer acting benzodiazepines. You could, or Librium for that case, the chlordiazepoxide. Phenobarb, you can use a barbiturate for the same thing. And then there's a lot of comfort measures, right? So we're using things like ondansetron for nausea, that's Zofran. And then you can help people sleep with medication as well. And you can kind of tamp down the anxiety that can come with that with clonidine. So just a little bit more information. Early symptoms of withdrawal. So this is, I've seen this in people that have come in who have been drinking huge amounts of alcohol, and they've come in within probably 8 hours of their last drink wanting treatment. And that tremor, nervousness, sweating is people just profusely sweating in your office. But they're not really getting in, to that point of the DTs, which takes about 48 hours to start up after their last drink, which, let's remember, the DTs can be life-threatening. And pretty uncomfortable experience. So naltrexone, that's the Rivian and Vivitrol that I was mentioning earlier. Sorry about that confusion. So naltrexone is a mu-opioid antagonist, and it can be used in a variety of ways for different things. But the way that we use it for alcohol is it is supposed to reduce cravings, or it is supposed to reduce the pleasure that we get from drinking alcohol through this antagonistic action on opioid receptors. So I've had people report to me that this works pretty well. Those of you who work in substance use could probably chime in on this one. My experience with naltrexone is it seems like it works really well in the first month or so, 6 weeks, and then it doesn't seem to work as well after that. That's just kind of my experience. I haven't read anything about that very much. Danielle's saying, yeah, she thinks so too. So it as a long-term option, not that great. One of the drawbacks of naltrexone is going to be that it is a mu-opioid antagonist. Joya says we've had some people on it for a long term, but usually switch to Vivitrol. So a couple of people have said that they've done pretty well over the long term on it, and we use it for self-harm, which is, oh, that's interesting. Using it for self-harm, that is interesting. Okay. Huh. Naltrexone, one of the big drawbacks on naltrexone is that it's an opioid antagonist. So were you taking naltrexone and you go out and you get into a car accident and break your arm or your ribs, and then you go to the emergency room, they're going to want to give you an opioid for your pain. That's going to be a problem. I remember a provider that I was treating once, and we had decided to use naltrexone with him, and he was really mixed about it. He was in his 50s, and he said, what I worry about is that I'm going to have a heart attack. They're going to have to crack my chest open, and I'm not going to respond well to opioids, which I thought was a reasonable concern. The self-harm that Joy, so when you say self-harm, Joy, I assume that you're thinking of like SIB, self-injurious behavior without the intention to kill yourself. So it reduces the pleasure that that was going along with the SIB. So acamprosate is interesting. I haven't personally used this one, and you can see its mechanism there, reducing glutamate and increasing inhibitory GABA. So I don't know if anybody's had good experience with that. Okay, so that's alcohol. Let's hit nicotine relatively quickly. So there's been a lot of stuff since this book came out, and I reviewed this book. A lot has come out with exploding e-cigarettes and whatnot. Theoretically, e-cigarettes are less harmful than tobacco cigarettes because there isn't the other chemicals in them, but who knows what chemicals are in those? I don't really know. But we're really just focusing on tobacco here. Behavioral techniques are the main approach. We do know that we can use Chantix or Zyban, and remember that Zyban is also Wellbutrin, right? Bupropion. And that usually used for 3 or 4 weeks, 150 milligrams of the SR BID. And I think the emphasis on this is that, you know, you should encourage attempts to quit because people take many attempts before they actually get to the place where they stop using. Nicotine replacement, gum or patches can be used there as well. All right. Oh yeah, from Rebecca, Chantix had a class action lawsuit for suicidality. Suicidality, my memory is now I don't prescribe Chantix, but my memory of Chantix is that is actually a known adverse reaction is depression and suicidality. I have to look that one up, but I'm not surprised to see that. I certainly know depression is a potential side effect of Chantix. So I think on what I will say here is on sedatives, excuse me, is sedatives are often abused and there's no real medical treatment for them. It's supportive measures. I think what's important for us here is that these medications are abused, and we need to know that because we prescribe them, right? I think it's interesting when we think of the mechanism of action. I really like the concept of when we went to the Z drugs, right, from the benzodiazepines, the idea that the Z drugs, zolpidem, azopiclone, zolpidem, all of those sleep agents, their real idea is they thought that they would target the alpha-1 subunit only, and not the alpha-2 subunit that really hits anxiety. So they were going to make these basically sedating drugs that were not anxiolytics and theoretically, therefore, less likely to be abused. So I don't know that that's true. I think I've seen Ambien or Zolpidem be problematic for people before. Clearly, the benzodiazepines are problematic. And I would say that I've seen more people have a problem with benzodiazepines, not because they were going out seeking benzodiazepines, but because when they got to me, they were taking, 2 or 3 milligrams of lorazepam 3 times a day from somebody who was prescribing this for them. And so frequently we're in the position of having to deal with what we get rather than starting out fresh. I do want to make a couple comments on that after I talk about the benzodiazepines and Z drugs here. I had a patient who was a nurse who was taking a benzodiazepine and a Z drug at the same time, and I discontinued the benzodiazepine because I didn't want her taking a benzo and a Z drug at the same time because of the overlap. And that became problematic for her, and she began losing her medication, et cetera. It eventually turned out that she was taking, and this just shocks me, 180 milligrams of Ambien a day, which is, now remember, Ambien, an immediate release Ambien, not the CR version, it goes up to 10 milligrams a day. That's the FDA limit. That is a phenomenal amount of Ambien. And yeah, I know, 160 milligrams. So I like Abdullah's, what? Yeah, absolutely crazy. So these certainly can be abused. Yeah, still alive, yeah. She, she built up her tolerance over time. She did have to be detoxed, essentially, right? She had to be tapered down off of this medication in an inpatient setting. This is what let me see what my next slide here is. Z-drugs, barbiturates. I think this is all I want to say. Oh, I do want to mention this. You saw that connection in 215. It was a pretty big deal between long-term benzo use and the development of dementia. More recent studies call this into question. I think that's something that we're going to continue to follow and be interested in watching. I'm not going to talk more about sedatives. I think at this point, medical treatment is supportive. The treatment that needs to happen is really behavioral, right? Intensive outpatients, 12-step, et cetera. Treat underlying issues, right? Whatever else happens to be there, if it's PTSD or depression, anxiety. We talked about naltrexone and camprosate, and we're going to get into cannabis. Before we launch into cannabis, I want to talk about something that's going to be related to the hopefully relatively short assignment that I'm going to give you for between this weekend and our weekend of case presentations, which is when I was taught in New Mexico through the SIAP NMSU program, benzodiazepines were evil and bad, and I was taught that they were evil and bad, and so I was never going to use benzodiazepines. And then, you go out and you get taught all these things, and what you discover is, as a prescriber, you get what you get. So you can be anti-benzodiazepines if you wish, but that doesn't mean that you're not going to get a patient who's going to be on 3 milligrams of Ativan 3 times a day and land in your lap, and you have to decide what to do with them, and you can't discontinue them today or refuse to prescribe it if you're the provider because you risk death. So the thing to do is you have to figure out how to deal with and manage what other people have started or created, and in those cases, what I do is I very carefully taper people off of those medications and give them the rationale for them. And that is, by the way, not to say that I don't use benzodiazepines. I actually have found that benzodiazepines have a very useful niche. I have a pretty strict way of prescribing them. I don't go above relatively low doses of them. So the most you would ever see me prescribe is 1 milligram of Ativan 3 times a day. And that is almost excessive for me. And that is not a long-term plan. So I tend to be very cautious. Most of my patients who are taking a benzodiazepine are taking 0.5 of Ativan or clonazepam, and they're using it as a rescue medication. And I only give them a limited amount with limited refills. With that said, benzodiazepines seem to have a fairly important role in my experience with bipolar patients, which when we get around to that, I will talk to you about. And the foreshadowing for your assignment is that I'm going to be having you determine how to respond to getting a patient who's on some significantly interesting medications that you inherit from another prescriber, and deciding what to do from there, because I find that is actually a very realistic kind of real life experience that I've had to deal with much more often than I would have thought would be the issue. Cannabis, that limited evidence, again, this is a summary of Dr. Weaver's stuff. I think that we're going to see, my personal view is that we're going to be seeing a lot of medical uses for cannabis in the future. That is my expectation. Now that it's legal in some of the states, I think we'll see more studies that are well done looking at the roles of cannabinol and what the uses might be, but we'll see. No effective medication to treat marijuana use disorder. Cannabinoid receptors. So I'm actually, guys, I'm gonna move through this pretty fast because I don't really have anything to say about medication with this in regards. Okay. Eddie, so I think there's a study showing that it interferes with fear extinction. I think you're talking about cannabis at that point. Yep. And yeah, I don't see that would be any different than the interference that benzodiazepines have with fear extinction, right? I mean, that would make sense. Like one of the reasons that we're not treating specific phobias with, you know, our hierarchical extinction plus benzodiazepines, because the benzodiazepines interfere with the fear extinction. All right. I don't know if anybody's noticed, but the opioids have become a problem. So this is perhaps one of the biggest thorns in the sides of family practice providers and probably internal medicine as well. My personal view on this is we just don't have anything that's that great for pain. And so we fall back on what we have, which tend to be the opioids. And they're not that great for treating pain, and they've got all sorts of attending problems with them, right? And so part of the problem is we just don't have a great way to treat pain. And I kind of want to start with that place. And there are, you know, opioids can be abused because people are using heroin, and opioids can be a problem because they're overprescribed. So there's a variety of ways in which opioids can become a problem. You should be aware of whatever opioid somebody is on, it can be converted into essentially morphine equivalents. And so taking Percocet or Vicodin, whatever it may be, oxycodone, they can be changed so that the metric is the same, so that we're looking at morphine equivalents. And that's generally how that is done. Our hospital has assigned a pain champion to every clinic, essentially, who is supposed to be working with patients with chronic pain. And we have essentially any patient who is taking an opioid gets naloxone injection kit and a sole provider contract. So for opioid addiction, a couple of options here that we're going to talk about. Medication-assisted treatment. That again, for those of you who are working in substance use, my understanding of the latest out there is that sending people away to expensive inpatient programs to get them off of opioids or heroin doesn't work, because they're off while they're there, and then they get released back into the community where they get exposed to the opioids again, or they have access, and it's highly addictive, and they re-abuse again or re-offend or whatever it may be, and they're back in the same boat or they die. So the medicated assisted seems to be more successful for long-term maintenance of these patients, in which you replace the heroin, in this particular case that we're talking about, with methadone or buprenorphine. So methadone is a fairly straight replacement for that. Buprenorphine is also, I believe, a partial agonist. So let's talk about buprenorphine first. Semi-synthetic opioid comes in a variety of forms. It's a partial agonist, right? So you're going to get some opioid action, but not a complete opioid action, right? So the high is less intense. And again, we're really aiming for people to feel normal on these drugs. And the people that I've seen have been taking Suboxone, which is, we'll talk about that in a little bit, which is buprenorphine and naltrexone. They seem, when it works, they just feel normal. They're able to go about their day in a normal way. It's really a remarkable breakthrough from them, where they really are able to recover and do well. They are dependent on the buprenorphine, but they get their lives back, and they're less likely to die of an overdose. Okay? Buprenorphine, you have to have a specific waiver in order to prescribe that. And at this, prescribing psychologists do not prescribe opioids, which is a blessing, by the way. So we're going to talk about Suboxone here. I said naltrexone when I meant naloxone under buprenorphine. Sorry about that. Let me see what Carmen says here. Oh yeah, just kind of everybody can look at Carmen's comment there. So buprenorphine and the naloxone combination, basically, so naloxone is a opioid antagonist, right? I mean, that's the thing that we use for basically a rescue medication when people have overdosed on heroin or other opioids. So you would say, well, how would this work? Well, basically, it's an attempt to keep people from grinding up and injecting it because the naloxone would inactivate it. But you take Suboxone, in this case, or Subutex, and sublingually, the buprenorphine is then absorbed, but the naloxone is inactivated. So it's kind of a tricky way to keep people from hopefully abusing it. I'm sure there's a way to abuse it if you want to. So methadone may be a little more dangerous. You have to go to a methadone clinic, and that's a daily thing. So you actually have to live near a methadone clinic, have access to one, frequently publicly funded. If people need a lot of supervision, having to go every day is good. It's good for people with high tolerance to opioids. Since it's so controlled, if they've diverted medications in the past, it's a good way to control that. Less expensive, people with less social support. So we often see people with, whether right or wrong, people with lower SES ending up in methadone maintenance. Disadvantages, greater risk of overdose, right? More potential drug overdoses, drug interactions, and the rare QT prolongation. We talked about naloxone and Narcan. Of course, this is, like I said, anybody who gets an opioid at my hospital, I don't know if this is true in other places right now, get naloxone and injectable naloxone. It's kind of like an EpiPen with naloxone, so that they can use it as a rescue med. We've talked about naltrexone before, right? Remember, that's the mu opioid antagonist. The long-acting injectable, you can see where that would be helpful. And we're going to kind of move through these. Okay, physical effects. I'm going to let you go through and sort of review these if this is an area where you have a lot of interest on these slides. is really our treatment options. And typically, people end up on maintenance, medication-assisted treatment. And we've kind of talked about this already. So we've already talked about naltrexone, talked about naloxone. This is a Probufene. I have not seen this one used. Subdermal rods, that's interesting, and 6 months of action. The buprenorphine combination. Kind of a clonidine-like drug for opiate withdrawal. And some of the psychosocial interventions. And obviously, when you treat whatever depression or anxiety or other underlying issues are also there. Often there's a lot of psychosocial issues and wreckage that needs to be worked through. We want to avoid, of course, anything that's can be addictive. Hydroxyzine is a good choice. Have you guys talked about using hydroxyzine as an alternative to benzodiazepines for anxiety and sleep? That's a question for like a yes or no's. Okay, so I got a couple of no's. Okay, let's talk about it. So hydroxyzine is Vistarol, and it is a potent antihistamine, very anticholinergic, and it is FDA approved for both anxiety and sleep. It works in about an hour, kicks in about an hour. You can dose it anywhere from 10 to 100 milligrams. You can dose it 4 times a day if you want. You could take 100 milligrams 4 times a day. That's actually within FDA guidelines. I don't typically do that. Generally, most of the people that I have taking it are taking 50 milligrams. That seems to be 25 to 50 milligrams seems to be a reasonable anxiolytic dose. Although 100 milligrams is pretty standard for me for sleep. It's non-addictive, non-dependency forming, and if you have hives, they'll go away. So hydroxyzine is a really great alternative to benzodiazepines. When I first learned about this, one of the things people would tell me is that hydroxyzine is a great drug for benzodiazepine naive patients, but doesn't work in those who've had benzodiazepines because they kind of expect it to be a benzodiazepine and it doesn't have that same feeling or experience. That has really not been true for me. I have switched people from benzodiazepines to hydroxyzine. The other name for it, besides Vistaril, is Atarax. And I've had them do well. You have to explain to them that it's not a benzodiazepine. It's not going to kick in 20 minutes. It's not Xanax. But for the people it works for, it is a great alternative. I would say that my hit rate for people doing well on hydroxyzine is about 50%. So it's really worth trying out as an alternative. And I have plenty of patients with substance use histories that I will not use benzodiazepines for, and they need something for acute anxiety. And hydroxyzine is where we go with that. It tends to be more sedating, I think, sometimes than the benzodiazepines. But my argument to patients is, when you're tired, you're not anxious. So, if we're really looking at this acute panic or acute anxiety that is so uncomfortable, yes, we may make you tired, but it may take care of that symptom. It's not perfect, but it's a good choice. So really, hydroxyzine is one of those drugs that you want to have kind of in the forefront of your mind as one of your alternatives. Doesn't really interact with anything. You do need to be careful with hydroxyzine during like breastfeeding because of its anticholinergic effects and whatnot. And I do not believe you're supposed to use it during pregnancy. But other than that, it tends to be a great choice. And that's one that you ought to consider, even before you sometimes consider benzodiazepines. Okay, so stimulants, no pharmacological treatments for stimulant abuse. So I'm really not going to spend, again, too much time on this. Antidepressants don't work. I'm not sure why I created like Uncle Dave's crack recipe slide, but apparently I did. I seemed like the thing to do at the time, but here you go. There's don't do this at home. You can go back and I think review the slides on stimulants at your leisure. Just again, remembering that these are drugs that we are going to prescribe and that we need to track and that they can get diverted. Designer drugs, I think it's important to have some awareness of these. I can't keep up with all of this stuff. We got the spice and the bath salts and everything. So these are some good slides to sort of just get you up on some of these things if you're not already up on these things, right? You can take a look at these and how they're marketed. A short version, if it's synthetic, it is probably really bad for you. Not that the non-synthetic aren't bad for you, but they tend to have more cardiac risk, and Lord knows what also has been put into these things as well. So classic hallucinogens, PCP, ketamine, which of course we're using for depression and suicidality now. All right, and getting a little feedback there. Okay. Somebody have their. I think somebody has their mic on. Roofies, inhalants. Again, go ahead and review those at your leisure. Okay, so we're going to go to questions here. Before we go into the questions that I was going to ask you, does anybody have any questions or comments about that section? Okay, I'm going to go with a no on that one. Oh, wait. That's funny, Eddie. Okay, so let's go to questions. So the heritability of addiction to drugs or alcohol is estimated to be at? Okay, get your answers in. I'm going to shut it down here in a second. Okay, let's take a look at the results here. Yeah, that's correct. 60%. It's quite remarkable. Okay. Now, Trexone is a mu-opioid antagonist. It's supposed to be that, can be used to increase alcohol abstinence. So you've heard of, there's a lot of debates about controlled drinkers. Can people who have an alcohol problem kind of revert back, still drink alcohol, but be controlled? I think that's more popular in Britain than it is here. But I I think naltrexone can be a step essentially in that direction, and that people, because they're getting less of the pleasurable experience with the alcohol, they tend to drink a little bit less. So it certainly can cut down on binge drinking. Okay. And here's your results. Yep, that's true. Okay. Opioid abstinence may be significantly enhanced by using partial opioid agonists, such as for medication-assisted treatment.
No.
All right, let's give it just another minute. Well, not even a minute. Let's give it another 10 seconds. Is it naltrexone, disulfiram, buprenorphine, or naloxone? And the answer is buprenorphine. That's correct. So people got that right. That's good. Okay, we're about to launch into antipsychotics. I think somebody has their, check your mics. I think somebody has a mic on. Okay, so it is about 2:50. What I think we probably ought to do now, guys, is go ahead and take our next 10-minute break, and then we'll carry on with antipsychotics for about 50 minutes, finish up with questions, and then we'll be done with today. If you have any questions in the short term or any comments that you want to shoot, you can send those to me now, and I'll see you all in 10 minutes. Give me 1 minute. I'm gonna okie dokie. There we go. Okay. Antipsychotics. Everybody ready to roll? Saving the easy stuff here for the end. Okay. So my guess is that we'll end up splitting the antipsychotic part of the lecture between today and tomorrow. This is based on a slide deck that usually takes me about 3 hours. So we'll decide how we want to go through this and how much time we want to spend on it. Out of curiosity, so I find that atypical antipsychotics are becoming more and more prevalent, and I really feel like this topic is incredibly important for us as psychologists and prescribing psychologists to really understand how they work, understand how to use them, understand what the pros and cons of these medications are, and be able to advise others on how to use these medications. They're here to stay, and they keep developing new ones faster than I can memorize them. And we need to be well-versed in using these. And I will say that I use atypicals on a regular basis and find them, for the right people under the right circumstances with the right diagnoses, to be remarkably effective. But they have some real serious problems too. So we're gonna go over that. So if I do go, Maribel, I appreciate your comment. If I seem to be going too fast, slow me down. I'm a fast talker. So if I start skipping over stuff and you want to go back on stuff and understand it better, that's fine with me. I'm happy to go back and do that. All right. So let's start out with the absolute basics, which is all antipsychotics are going to block D2. There's our friends in pharmacy are like, hey, what about cariprazine, Vraylar, right? But remember, it does block D2. It's just that it's more prominent antagonist at D3. And it also doesn't seem to be a very decent antipsychotic, which is interesting. But we will talk about that when we get there. Okay, so some common conventionals. These are not atypicals, right? Conventional or first generation antipsychotics. I don't know if you guys are seeing these out there much. I have used Haldol and I have used Melril. But I don't see patients in general coming to me on these medications. Now, I don't work in a chronic mentally ill population, and I don't work in inpatient. So, so you may see these more often depending on the setting that you work on. Maribel mentions that she's Prolixin. What we'll probably see a lot about or see a lot of are the atypicals. The one that Rebecca, I'm going to answer your question. You said slides that you say we can review on our own. Will they be on the test? The test, everybody, I just want you to know you're taking the test. As we go through this, I've embedded the test questions. And when you vote on your answers to those tests, that is the test for this course. I've embedded it. I want it to be part of kind of organic to the process that we're going through in this. And I want you to be thinking it through as we talk about it. I think that there's more learning that occurs that way than in just taking a test at the end. So let's try to be smart about learning on this. As far as I did say, so yes, no test after the class. send cash if you'd like to thank me. I did mention a slide deck that we were going to review tomorrow. That is not a test. That is actually just a review of the case presentation that we're going to do. And I'm going to send that to you. So we'll have time to go over it, but then you'll be able to review it at home when you're putting it together, okay? All right. So. Well,
Doctor, if I may interrupt at this point, is it okay if I run the attendance poll?
Yes. Kirsten, I just saw your question. No, you have passed. You have passed by being here. We're all grown-ups and we're all good learners. And I answer questions wrong, and then when I see what the right answer is, then I learn from it, right? So it's okay. It's all good. And yes, Aiden's doing a great job. All right, Aiden, are we done with the poll yet?
Yes, we're done.
Can I get rid of it and start talking again? Sure. Okay. All right. All right. this is where I was looking to get the award for the busiest, most incomprehensible slide. How am I doing? What we are doing here is I love this slide. And the reason I love it is so you're going to look down on that left-hand side and you're going to see not all of the atypicals because they keep adding atypicals, but there it is. And then across the top, you're going to see the different neurotransmitters and subneurotransmitters that these medications, for the most part, antagonize. So looking at this, you can really see, you can really like figure out which medications are more likely to have which side effects, right? But it also gives you a picture of how complex these medications are, right? Now, you can see the ones that are super complex, like look at, I believe olanzapine ends up being, yeah, look at olanzapine. Oh my God. That's wild, right? And then you can look at some of the other ones that are like sulpride, which is less so. Where is Abilify? Yeah, Abilify is pretty messy. PA, by the way, means partial agonist. This is an amazing, it just is a way for you to kind of soak it in and get a feel for what this looks like. And we're going to break this entire thing down and talk about it, but I'm going to bring it back up a couple of different times. And this is how I believe we need to be thinking about these as multifunction drugs. And this very slide is why they work for so many things, right? I mean, we're using them, and I'm going to talk about that today. I'm going to talk about stuff that we're using them on label for, off label for, things that people shouldn't be using them for that they're using them for. These are being used for absolutely everything. And we're going to talk about the evidence for and against that today, all right? So we kind of just talked about this, right? Different atypicals have different binding properties. Here's just another way of looking at the same thing. This is a NEI slide. So if you're familiar with Stahl, you know, he likes his graphics, and I think his graphics are great. And you look at this, this is essentially, here you go, here's the atypical and everything that they potentially can hit, right? So you've got your acetylcholine receptors there, M1 through 4. You got your histamine receptor, adrenergic receptors, transporters, serotonin, norepinephrine transporters, dopamine receptors. And of course, they go beyond like 4, it goes 6, 7, right? 5, 6, 7, probably more. The serotonin family. Thank you very much for all that serotonin. Okay. Now, why are we using these medications for treatment-resistant depression? I wonder. Right. So there it is again. All right. Now, it drives me nuts that it changed my slides. Being OCD, I feel like I should fix it. Let's see here. It's not going to let me fix it. All right, you guys have to put up with sloppy slides. I'm sorry about that. Okay, so the much abbreviated on this is really true. This is much abbreviated, right? So our pharmacists, yes, I know that it goes far beyond this. But to give you a feel for the antagonism and kind of what we're doing, so looking at D1 agonists, precognitive agents, so we may have something there. D2, we know that antagonism and the mesolimbic pathway, and I'm assuming you guys have looked at the pathways, the dopaminergic pathways, is that right? Mesolimbic and, okay. So I'm not going back over the pathways, but we're going to refer to them occasionally. Precognitive in this, yeah, I know. What is that? What does precognitive mean? I think we're talking about the areas of the brain responsible for some of the executive functioning. I think that's kind of where we're at with that one. D3, Taking antagonists may help both negative and cognitive symptoms and reduce stimulant abuse. Okay, interesting. And interesting that Vraylar, cariprazine, one of the newer ones, is a predominantly a D3, and we'll talk about that one and my experience with that medication. D4, not really sure. 5-HT1A. Remember now, think about for 5-HT1A, what is a 5-HT1A partial agonist? Which medication, right? Remember that's buspirone, right? So 5-HT1A antagonism, we're mostly talking about antagonism here, accelerates dopamine release. You see the hormones, cognition and depression. The 1B and D, influencing serotonin. But in that, you know, that really simplistic idea that if you increase serotonin, people get less depressed. It's you increase serotonin, then all sorts of other things happen depending on which subunit of serotonin you're affecting, right? 5-HT2A is a brake on dopamine, unless you antagonize it. And you can read 2C there, looking at weight gain, 5-HT3. Some of the SSRIs will make you nauseous, right? Interesting. 5-HT6, brain-derived neurotropic factor. That's interesting in terms of a protective factor potentially, right? 7 for circadian rhythm. Alpha-1, we're familiar with this with like clonidine. Antagonist, sedation, decreasing blood pressure, nightmare prevention. The alpha-2s, right? So I think guanfacine is an alpha-2. Inducing insulin secretion and decreases blood sugar levels. Interesting, right? Thinking about the diabetes and risk of diabetes. H1 antagonism, awakening and sedation. Muscarinic, anticholinergic, right, sedation and drying. M3 is very interesting there. Insulin dysregulation. I'm going to talk about that and what that impact that may have. And M4. Okay. And this is just a little, if you insert M1, you're going to get a massive anticholinergic experience. So constipation, dry mouth, blurred vision, and dizziness, not unusual side effects for our atypicals. So the thing that makes an antipsychotic conventional or typical, if you will, is antagonism at D2, all right? But which leads to the question, I think, really is what makes an atypical atypical? What is it why are we calling these atypicals? And I'm going to go over 4 things that are related to why we consider them atypicals. Now, one of the big problems that we had with blockage of D2 with the conventional antipsychotics is you could get extrapyramidal symptoms, which were problematic, and eventually you could also develop what? Can anybody throw out that term? TD, tardive dyskinesia, thank you, sir. Tardive dyskinesia, right? So a movement disorder. So conventional antipsychotics are going to block up to 90% of the D2 receptors, and atypicals are 70 to 80. The idea being that there's a threshold of blockade or antagonism that can be reached, which makes it more likely that people have EPS. And that if that antagonism or that blockade is at a lower percentage, then perhaps that's why we're avoiding EPS. And the truth is, for the atypicals, we see a lot less EPS in the atypicals. Now, that doesn't mean that we don't still have to look for extrapyramidal symptoms, and we do see them. A patient that I have on a low dose of lorazepam, which is Latuda, 20 milligrams for treatment-resistant depression, which is working beautifully for her. I gave her the Ames. Is everybody familiar with the Ames? Do we know what the Ames is? No? Okay, I got one no. I got no's and yeses. So I'm going to go, I believe I may have a form in here on it. It's the abnormal involuntary movement scale. And anyone, okay, if you have anyone on an atypical or atypical antipsychotic, you have to have a copy of the Ames in your office, and you need to be doing it on a regular basis. Probably initially, and there are some guidelines on this that I have not memorized, but essentially when I start somebody on this, I'm going to be monitoring this every couple of months, and then every 6 months thereafter, probably I'm going to give somebody an Ames. We can administer the Ames. It's a very simple, straightforward process. And if your score of Ames is 1 or higher on that, you have extrarandal symptoms, and you have to decide how to go forward with that. And we'll hopefully, if the Ames isn't in here, I'll see if I can't find a copy of it and put it up. We can look at it and talk about how to use it. Oh, did you say what does it stand for, the Ames? Abnormal Involuntary Movement Scale. So, again, diagrams from Stahl, a conventional antipsychotic antagonist. So it's real good at the antipsychotic, but it causes EPS, is what they're saying there, right? Got too much blockade, right? And kind of just looking at it the other way, right? Not enough blockade, we've got psychosis. So we're looking for Goldilocks, just right. We're looking for that balance between the agonism and antagonism. So we get fewer side effects and the therapeutic effect at the same time. All right, so let's talk about what makes an atypical atypical. Number one, remember there's 4 of these. So we talked about 5-HT2A a little bit earlier. We were talking about the interaction between serotonin and dopamine. So if 5-HTA normally blocks dopamine. If you antagonize something that blocks dopamine, you're going to get stimulation of dopamine, right? So you stimulate dopamine release. Well, that's weird, right? Now, wait a minute. So what we're saying is atypicals, we have an antipsychotic here where we know that we're antagonizing D2, but at the same time, we're adding something that's going to stimulate dopamine release. The idea here is that by increasing dopamine release, that maybe in some of the dopamine pathways, perhaps the mesolimbic, right? Think nucleus accumbens, we're going to reduce some of the negative symptoms that are caused as a result of excessively blocking D2. Here we talk about the mesocortical dopamine pathway, right? It's going to have that projections up to the frontal cortex. So blockading D2 in that frontal cortex is we're going to get that dulling and effective flattening. But if through 5-HT2A antagonism, we're increasing some dopamine or stimulating some dopamine release to those areas just a little bit, maybe we can reduce some of the cognitive dulling and flattening as a result. Is that basically a picture of that? Additionally, antagonism of 5-HT2A can reduce glutamate release, decreasing excitation, and therefore reducing hallucinations and other positive symptoms. So another mechanism through which it might work that doesn't involve directly dopamine. And I think if you're reading much of the literature or looking at the literature on psychosis, you know that one of the next big areas of research is really, or not even next, it's happening now, is looking at glutamate, the excitatory neurotransmitter, and its role in psychosis, and how we can use that and NMDA to modulate um, schizophrenia and other psychotic disorders. So one of the problems that we have is that if you block D2, D2 puts the brake on prolactin secretion from the pituitary gland. And so normally that's in place. But when we, because the D2 is present, it's agonized at that location. The D2 is present, but when you block it at that, you take the brakes off of that, and you end up having the prolactin secretion, which can result in hyperprolactinemia, right? So the secretion from the breast, and that is particularly true for a couple of the medications. Can anybody think of the ones that are maybe more likely to receive hyperprolactinemia? Yep, good job, Risperdal. Risperidone and its relative paliperidone, but particularly risperidone. I mean, I've multiple patients who are on risperidone who've developed that. Well, this antagonism maybe can improve that. All right. So, everybody with me so far? Are we going okay at an okay pace? Okay. So, remember the last one, 5-HT2A antagonism is going to increase some dopamine stimulation. So we've got dopamine blockade and stimulation at the same time, right? Remember that Goldilocks thing that we're looking for? So number 2 here, rapid dissociation of D2 makes antipsychotics atypical. Rapid dissociation. So when you think about the dopamine neurotransmitters sort of locking into those receptors or antagonizing those receptors in this case, imagine it rather than just locking on like a big lip lock, right? It's more like butterfly kisses, you know, on and off, on and off, on and off, on and off. That's rapid dissociation. So it's blocking it, but not all the time, right? So it's kind of phasic. It's just on and off, on and off, on and off and off. And so by doing that, that can also reduce the amount of occupation about blockade of D2 from 100% or 90% down to that 70 to 80% sweet spot by doing the rapid dissociation. Okay. Some other ways of hit and run or slipping off easily. Now, the conventional antipsychotics, those are lip locks. They just lock on and they're done. They're just going to hang on to that. So enough binding to get an antipsychotic effect, but not so long to cause the EPS. So this is kind of a theoretical, but I think a nice pictorial of this. So the idea being that if you kind of cross that black dotted line there, you're going to get APS. But if you have to be above that little red line, but below that black line, and that's the sweet spot that we're aiming for with the atypical antipsychotics to get a great therapeutic effect and not too many side effects. Now, interestingly, rapid dissociation does usually coincide with low potency. So if you think of a low potency agent, so quetiapine goes up to 800 milligrams. I actually don't use clozapine or clozaril, so I don't know the dosages on that. But some of the others with higher doses. That's interesting, Eddie. I'm going to respond to that in just a second. Let's see. Let me run through them in my head. Not really olanzapine, Abilify, nope. What are some of the higher dosing ones that we have? So olanzapine stops at 20, and Abilify stops at 30. But in any case, the lower dose ones, so Risperdal goes up to 8 milligrams, right? So that's a high potency drug. So some comparisons show you that low potency versus high potency in terms of rapid dissociation. So again, looking at how you can choose a medication for a particular patient and how that mechanism of action works. So Eddie had a note here that EPS can happen early too, that developed EPS shortly after initiation. And yeah, it can, absolutely. We would like to think, or at least I think initially I sort of thought, the way I thought about this was that, you know, people would start on these antipsychotics, and that after time, as we slowly titrated the dose up, they would eventually cross some sort of threshold and would develop EPS. And that tends to be relatively true, but not for everybody. There are some cases you start people on one of these medications and they can have EPS right off the bat. And you know, whether that's something about how they are physiologically put together and their brain chemistry, I don't know, but you certainly have to keep an eye out for this because it can happen kind of at any point. Okay, so our first point was we were increasing kind of the opposite of blockading D2. We were actually adding some stimulation of dopamine, right? We're trying to find that Goldilocks. That second point there for what it made atypical, we were talking about rapid dissociation, kind of jumping on and off the receptor. So number 3 here is partial agonism makes antipsychotics atypical. So D2 partial agonist. The DPA, that would be like aripiprazole or Abilify. So I like to think of partial agonists really as like a dimmer switch, okay? And that it's if it's too bright, you turn it down a little bit. If it's too dark, you turn it up a little bit, right? And so it's a way of sort of finding that sweet spot. Again, not too hot, not too cold, kind of finding that middle space. That's a partial agonist. Remember, another partial agonist we've been talking about is buspirone, right? A 5-HT1A partial agonist. So dopamine partial agonist, just another way to not go overboard on the dopamine blockade. And you kind of see the partial agonist spectrum here. Maribel, I see your question. Why not always go with a partial, then go up and down? I'm not sure I understand that. Why not always start with a partial? Is that kind of what you're asking? They have their problems too. Yeah, they have their problems too. And so, whereas it may seem like the perfect drug, I don't know if any of you have used Abilify. I've used Abilify with great effect in some people, and I've had other people that do not tolerate the side effects of Abilify at all. So even though it might be the perfect drug for them, they end up not tolerating it. You've seen poor effect on Abilify, yeah. Oh, you got some people who do not like Abilify. Akathisia can be a real problematic side effect of Abilify. Remember that cruel restlessness? I can tell you a story about that. Maybe this is the time to tell that story. Let me finish this couple of slides and then we'll do that. So here we have that, again, dopamine, just another way of looking at a dopamine partial agonist, right? Just trying to get that. This is the same thing, just another way of looking at it, right? That bottom one is the one we're looking at, dopamine partial agonist, right? But remember, that's not all these drugs do is dopamine, right? Remember all those other neurotransmitters and the interplay amongst them. So let me, before we launch into 4, I'll tell you about Abilify, which was, I had a patient who was a senior resident in one of our medical residencies, and he had intractable depression, just could not dig out. He ended up doing pretty well with ECT, actually. But before we got there, we were trying a variety of things, and I started trying Abilify as a adjunctive medication for treatment-resistant depression in addition to his antidepressant. He got a lot better on a fairly low dose. He felt a lot better. I think we were only at about 6 milligrams of Abilify, and things were fine, except when he came in and I saw him, it was just remarkable. His legs were bouncing, his knees were bouncing up and down while he was sitting. He couldn't keep still. It was just remarkable to see this true akathisia caused by the Abilify, and so we had to stop that medication. And people are mentioning weight gain with Abilify a lot too, as well. Okay, our fourth point, 5-HT1A. Now remember, we had talked about 2A. Now we're talking about 1A. And remember, this is 5-HT1A. Partial agonist is buspirone. Makes them antipsychotics, makes them atypical right here. And this is how. So it accelerates dopamine release and reduces glutamate release. Remember, we talked about glutamate earlier. The too much glutamate, particularly in a psychotic person, is a bad thing. So once again, we have another way of increasing dopamine at the same time that we're blockading dopamine, right? It's just another way to try to even that out so that we don't get too much occupation of the D2 receptors, and that we get dopaminergic stimulation to other areas of the brain that need it. So the frontal cortex, the nucleus accumbens, some of the places where we're seeing side effects as a result of the antagonism. Okay. All right. Any questions? Okay, so let's talk about, I'm going to address this in a variety, this question is one better than the other. I'm going to address this in a variety of ways. This is a slide that I inherited that I liked quite a bit. And so, no, well, maybe clozapine. Clozaril really does seem to be pretty effective. And I will tell you that I find olanzapine to be remarkably effective, but olanzapine's side effect profile is so bad that you just can't use it over the long term. It is super problematic. Second generation antipsychotics inconsistently more effective than first generation antipsychotics, and you can see that. So there's some talk about non-consistent differences in efficacy. Dosing is key. You know, they talk a lot about, you'll see ads for Abilify as an adjunct for treatment-resistant depression. It appears that low dose atypical antipsychotics aren't that effective. You really have to, in treatment-resistant depression, you really do have to dose them at appropriate doses. You can't do little baby doses of them and hope that they're going to work. That's kind of the strategy with lithium, is using a small dose of lithium as an adjunctive for antidepressants for treatment-resistant depression. But if you want an effect, you're really going to have to use a reasonable dose of an atypical to use it that way. We'll talk about why it's not an unalloyed benefit. Maribel, what I don't know what you mean, which is what? What is an effective dose of an atypical? That's a good question. Okay, so the when you look at the dosing guidelines for them, you're probably and you kind of learn this over time, but Abilify goes up to 30, and I've had maybe one person on 30, and I've had people seem to get a benefit from between 10 and 20 milligrams of Abilify. And you kind of end up having the same sort of, oh, for depression, same answer, right? So that's what I'm saying is that the way that they were advertising Abilify, it sounded like you could add 5 milligrams of Abilify to say Zoloft, 200 milligrams of Zoloft, and you get an effect. But it doesn't appear to be that way. It really appears to be that you use 200 milligrams of Zoloft plus, like what I'm saying right now, 10 to 15 milligrams of Abilify to really get an effect. Whereas it seemed at first, what we could probably do is just add like that 5 milligrams, okay? We're gonna talk about the side effects, and we're gonna talk about the good and the bad. Here's some data about people using second generation antipsychotics a lot. So it's getting to be a little bit older data, but you can see that people are using it a lot. And we'll talk about how that has changed over time in the last 10 years. Okay. So let's just kind of review extrapyramidals. So question from Carmen, when talking about dose, does this mean total per day, even when multiple doses? The answer is yes, it depends on the drug I'm talking about. So for Abilify, that's a once a day drug. And so that would be 10 to 15 milligrams of Abilify. For drugs like Geodon that you might dose twice a day, then of course I would have to indicate that that's twice a day, right? So it depends on the drug. Yeah, this is true. Most atypicals can be dosed once a day, most. So extrapyramidal symptoms, so we're really looking at the effect of blockamine, of dopamine blockage in the extrapyramidal areas of the brain, resulting in Parkinsonism, not Parkinson's, right? Parkinsonism. We'll talk about what that is. And then akathisia, it's that cruel restlessness, right? And acute dystonias. And we're going to define all of these things just as a reminder. So Parkinsonism, if you work with anybody with Parkinson's, you kind of can relate to this. It's the rigidity, akinesia, not moving, bradykinesia, slow moving, resting tremor. Also, we see with Parkinson's the shuffling gait, mask-like faces, etc. And one of the things we test, that rigidity, in the AIMS, we're testing for something called cogwheel rigidity, and it's really hard to, let me see if I can explain that verbally. So that would be like if you were to make a fist and make a muscle with your bicep, and then I would grab your elbow with one hand, and with the other hand I'd grab your fist, and I would start pulling your fist towards me away from you, and you would let me do that in a smooth motion. Cogwheel rigidity is when you can't do it in a smooth motion and it jerks all the way. It jerks an inch, jerks an inch, jerks an inch all the way down in a cogwheel fashion. And that's one of the things that we do in the AIMS. Akathisia, that we kind of talked about that earlier, and I gave you that example of that one patient who was just couldn't stop moving. Dystonias, if you've never had a dystonia, that's awesome. Dystonias are horrible. They're abnormal muscle contractions. As a youth, I had torticollis, which is a dystonia of the neck, and so my neck was sort of not pinned, but kind of stuck in one position, and it was super painful. And I treated it with muscle relaxants, and that worked over time. But horrible. Oh, really, Sarub? Yikes. So yeah, very, very horrible. And it can be in a variety of locations. You can even get ocular dystonia, which just always makes me feel like throwing up when I think about that, right? So getting basically a permanent muscle, not permanent, but a muscle spasm chronically that just pulls on one of the muscles that helps you move your eyes. I mean, just very horrible. So very painful. So tardive dyskinesia. And has anybody seen this? I feel it might just be because of my age that I've seen this. You know, back when we were using this. Oh wow, okay, a lot of people have seen this. Okay, good. Well, not good, but too bad. When I was younger, so probably in the 1970s, I would go around on a public bus in the small town that I was in, and I didn't know what I was seeing, but I was seeing tardive dyskinesia in patients with kind of the jaw, lips smacking and stuff, because back then it was much more common. They didn't have atypicals, right? Well, all we really had were the conventional antipsychotics, and you know, when that's your only tool, that's the tool that you use. And if you look at the risk of tardive dyskinesia, check this out, 5% per year cumulative. So if you're diagnosed at age 20 with schizophrenia and you're started on a conventional antipsychotic, right? I mean, you just add it up. At 5 years, your risk of tardive dyskinesia is 25%. At 10 years, it's 50%, right? I mean, this is a guarantee. 20 years, you're at 100%. The likelihood of getting tardive dyskinesia was extremely high and cumulative with years of use. And of course, there are some variations amongst people, and some people that maybe didn't get it, and some people that got it sooner. But this is sort of on average. And this is why it was such a big deal that there was the development of these atypicals. Neuroleptic malignant syndrome, always a risk, always, you know, can't be predicted, very dangerous, medical emergency. Obviously, you stop the neuroleptics, hydrate, consider a muscle relaxant. Can happen for anything essentially that blocks dopamine. So NMS, much less common or frequent. Metabolic syndrome, quite frequent. This is what we worry about. Okay, so I've got my alarm is going off here to remind me that we're wrapping up. Let me see what the next couple of slides are. I think this is a good place to stop because I really want to spend some time on the metabolic syndrome, because it's one of the things you really, really need to know about and need to assess on any patient who is taking this medication, or any patient who's going to take this medication. So I think that's where we'll stop for today. But I wanted to leave a few minutes at the end today for us to for anybody to ask any questions, make any comments that you might like to do. Okay, so let me tell you, I'm gonna sketch what your assignment's going to be between now and we do our patient presentations or case presentation. So what you're going to get essentially is is on pretty much the following. Oh, can everybody hear me? I just was told that my internet connection was unstable. Everybody still got me? I'll fade out at the end. Okay. Good. Okay, I was breaking up. Good now? All right. Okay. Tell me if it breaks up again. Okay. So basically what we're going to do is you're going to get everybody's going to get the same thing, which is you're a 32-year-old female who's taking 15 milligrams of Abilify, we'll say 30 milligrams of Adderall XR, and 100 milligrams of Zoloft. She's got MS, chronic recurring remitting MS. She's treated with Ocrevus infusions every 6 months. She has no obvious disabilities, but she does have ocular problems, vision problems, grip problems, grip strength problems. And again, this is the recurring remitting. So, she has times when it's worse, sometimes it's better. She's getting regular MRI. She certainly has quite a few lesions on her brain, but she doesn't have any obvious motor problems that we can see other than those ones that she's reporting. History of alcoholism, and she's diagnosed with bipolar disorder. So this patient is on that medication regimen. And what I'm going to end up asking you to do is this is kind of real life stuff, is I'm going to imagine that you inherit this patient. You're a prescriber. This patient comes to you, and they come from a psychiatric provider. And you have access to the psychiatric provider's notes, and the psychiatric provider and the patient say that this medication regimen works. Bipolar, that's a good question. We'll go with bipolar 2. And Eddie's question was bipolar 1 or 2, and we're going to say 2. So both the patient and the provider say that she has been stable for 2 years on this, and that after many attempts to find other medication regimens that work, this is the one that seems to work well. So this is the regimen on one more time. Yes. And by the way, this is not the only time you're going to get this. I'm going to give this to you again tomorrow. We have a few minutes, so I was going to give you a heads up on this, just so you could start thinking about it. But the regimen was going to be 15 milligrams of Abilify, 100 milligrams of Zoloft, and 30 milligrams of Adderall XR. And if I change that tomorrow, it's because I forgot. But basically, that's what it's going to look like. And you're going to be in the position that I often end up being in, which is you inherit this patient. The patient says it works. The provider says it works. And you go, well, okay, either I'm going to continue this regimen or I'm going to change it. And that is what you're faced with. And I want you to be able to write a solid paragraph of why the rationale for continuing it that you would put in a chart that would basically CYA you for continuing that medication with that patient. What is the rationale for continuing that medication other than the fact that she says it works? What is the rationale based on what you know about those medications and how they work and how they might be working for her and why they might be working for her and why you should continue her on those? And then I want you to write a separate paragraph. And again, don't do more than 1 page, guys, because this is like something that goes into a chart. We don't want long charts. So you need to do the exact opposite, which is you disagree with this and you think it should be changed. And then I want you to explain what you think it should be changed to and why. So you're basically going to argue from both ends of this. And that is the position that, frankly, if you become a prescriber, you're going to find yourself in on a regular basis, which is, do I continue this thing or do I not continue this thing? What are the risk benefits? Why might this medication regimen that I might not have started anyone on or even imagine going down this road with this particular patient, maybe some of it I would have, but not all of it. Why are we here, right? So that's what it's going to be, but I'll outline that one more time at the end of tomorrow so that you have it, okay? And then, yeah, Eddie says, yeah, especially with VA turnover. Yeah, I know. You never know what you're going to get. All right, guys, I think that's it. Aiden, can you stay on the line with me for a few minutes afterwards? But otherwise, we'll pick up here on side effects and risks of atypicals tomorrow. Everybody have a lovely evening, and I'll talk to you then.